Well, what's up, everybody? Welcome to another live edition of FlightBridgeED Live. Now, we're trying out a new platform tonight, so I'm going to be a little distracted while we got this thing going on. So I'm going to bring our guests in, all right? So I need to hit this button, and then I'm going to drag. I have to drag Dr. Sani in, and we'll see if he shows up. There he is. And then we're going to drag Bruce in, and then I'm dragging Bruce in. So there's Bruce. Well, I mean, I think it's coming, you know? Oh, wait. Oh, hold on a sec. See? That's what I'm saying. I have to send it live. It's a whole thing.
Now I'm live. Like, I've got the big bright, it's got a big red thing around me, and it says, "You are live." Live.
I know. It's like it's a whole TV production thing that is very difficult for one person to manage.
Well, I think we've managed to successfully do it.
We did, and it's our first time. So what are you going to do, right?
That's right.
All right. So the first thing that I'm going to experiment with is getting rid of all of us for a second, just I think the visual part, and I want to show off this little handsome devil. Let's see if he comes in. He took my spot. There he is. Oh, wait, I have to hit the button. See, I have to remember to hit the button.
Yeah, you got to hit the live button.
Hit the button.
There he is.
I can't. You're off stage, Mike. I can't hear you. So
yeah, right now Mike is muted.
Me and Bruce. Hi, Bruce.
What's going on, Ritu? What's going on? I was gonna try to introduce the little man here. So everybody, this is our latest edition of the Team Hoffman here. This is Jackson Lee, born about 1:30 yesterday morning, and mom and baby are kicking it up. They're doing well. We just got home, settling into the new life of a family of 5.
Congratulations, man.
Thank you.
So
I'll tell you, it's been a unique experience having a child during the pandemic, because a lot of the policies and a lot of the kind of logistics of having a child inside the hospital is different. It's unique. I think the 2 previous kids that we have, it's been very streamlined. It went very quick. This had to be a little bit more planned out, right? They wanted us to be COVID negative. There were masks and there were logistics about if the baby has a fever or if we have a fever, what you're going to do. It just kind of introduces a lot of different dimensions to what you think is a pretty standardized process. But lo and behold, right? We're done. We're home. We're good.
Congratulations.
I heard the little story we were talking before we came on here.
Yeah.
About the fact that it's a good thing you were sort of in the hospital when Mr. Jackson decided to come out, right? It was pretty expeditious.
So literally from like 4 centimeters, right, to like you need to, it's not going to happen for a little while, to like 20 minutes, kid was out and like starting to breastfeed, right? Like, so literally 20 minutes. We live about 45 minutes from the hospital where we delivered at, and we would have been delivering a child in the back of a Suburban on the side of the highway.
Trained to do that.
No, would not have been.
I've done it a couple times already, and I'd rather not do it for my own. So
that's
so
cool.
Good. So what's the baby's birthday?
Sorry, go ahead.
So the baby's birth date or birth weight?
Birthday.
What was yesterday? I think the 9th, July 9th. I'm telling you. I knew it. I said that we literally have, following a legend. I said Ritu and now Jackson Lee. It's amazing.
Right. So yes, yesterday was my birthday too. And I'm only 53 years older than your young man. So there you go.
You hardly look that, my friend. You hardly look that.
All right. So I'm going to do another experiment here. Okay. So it's probably going to seem like I'm going to blow up the world because I have no idea what I'm doing. So I'm going to try to do this.
And on the Facebook chat, there's tons of congratulations for you, Bruce.
There are tons
from Tyler, James Overcamp, Ed Zaffron. Oh, Ed Zaffron says happy birthday for me also. So just so you know, the crew watching is all excited.
Awesome.
Nothing blew up.
Good.
Thank you.
Well, yeah, that's very cool, man. Very exciting. You might notice we're missing two more people that were supposed to be on here. Like I literally said, we were going to have Jarvis and Bauer and Bruce and Ritu and myself. We're going to be 5 of us come to hang out, try out our new platform. And currently I'm watching Dr. Jeff Jarvis in the green room is what it's called. And he looks like he's struggling mightily.
He's hanging out at the buffet table in the green room.
Yeah. He's such a punk. He wants green only M&Ms, like Avion water. He's very hoity-toity. All right, so I'm gonna see if I can bring him in here. Hold on a sec.
Having some technical issues.
It's all right. So I'm gonna see if I can bring you in here, Dr. Jarvis. Stand by. There's that. I'm gonna hit this. It's so clunky with one person.
It says Jeff Jarvis is live.
Here's the man.
Got all the red border.
I am so confused. Now
you're in there.
Overly bright. Oh my God.
Jeff's been having he is on the struggle bus like you wouldn't understand. It's so good.
That's nobody's ever said Jeff Jarvis is overly bright before.
No, that's definitely, God bless it. Fuck it.
You should have heard. He's being censored right now. Like you should have heard him. It sounded like we were at some kind of a sailors convention while we were trying to get it set up.
Do you have a bleep button? Like
just for
bleep button.
We don't bleep shit out. So there you go.
Yeah, it's so funny. It's so good. Listen, so again, dual purpose. If you're joining us here, you are either watching on Facebook, YouTube, Twitch. I know there's some gamers out there.
There's a huge Twitch following that we have.
Huge Twitch following.
I should tell my son to watch Twitch.
And then over on Twitter. So welcome to our first sort of simulcast to all these different things. We've got a bunch of amazing stuff planned from FlightBridgeED's perspective. What?
I got nothing planned, so I'm looking forward to this.
You got nothing planned?
You said we have a bunch of stuff planned.
Oh, well, there's nothing planned. I'm talking down the road here as we get going.
We're talking in the future.
Yeah, in the future. Like tonight is going to we have stuff to talk about tonight, so don't worry about that.
Yeah, I know
what I'm saying.
Your job is just to sit back and look pretty.
Yeah.
Look all 53 and all.
Yeah.
Can we play What Are You Drinking?
Yeah, I would like to point out right now, happy birthday, by the way, but I would like to point out that you're 53 and I am a mere 52.
I know you're the child now.
I am. That's right. I like it.
You are younger than me now for 2 months. September?
November.
Yeah. Okay.
Hell, if we keep this spread up, I'm going to be younger than Mikey.
Bruce is the young man here.
That's right. That's right.
And it sounds like my connection is probably not very good. So I've seen a few comments out there that my audio is sort of laggy. So my guess is it's probably my connection. So sorry about that.
Well,
you figure it out.
Your laggy audio hits my crappy video.
Perfect. The new system's perfect.
I don't think this is the system. I think this is the new thing.
Actually. So
I think it's just a matter of being shitty.
Hey, you know what? You know what we do? It's just what we do in EMS. You take what you have and you make the best out of it, right?
Totally.
We can do
absolutely.
That. And here we even have drinks in hand. We don't get that, right? We don't get that on the road. I got to tell you right now, I'm just sticking with water. Ritu, what do you have?
So I am drinking, and I'm gonna put this. I'm gonna hold up the bottle here. It's a little bit of a special bottle. I bought it for myself for my birthday. But this is a local distillery in Portland. It is Westward Whiskey. We've had a couple of their products. I sent Mike a bottle of one.
Yes, you did for my birthday.
For his birthday, and they had this their 1,000th barrel. So this is their 1,000th barrel. They bottled it separately. So it's an American single malt whiskey, and then the the important piece too is that they taking all profits from this bottle and they're giving it to Micro Enterprise Services Oregon, which is a nonprofit, which basically funds like does micro loans to fund entrepreneurship and minority-owned businesses in the Portland area. So
that's cool.
So the message
awesome.
that was cool, and then it's the distillers signed the bottle, so that's kind of neat. So I thought I'd open this up and taste it. It's pretty good. It's pretty smooth. I would give it a, I think it's pretty solid. It's very nice to have on its, just neat because it tastes pretty good versus mixing. I didn't want to mix it with anything.
It's probably a good plan.
Mike, what are your thoughts on it? Have you cracked the bottle yet or not?
Yeah. We took care of that when we went golfing a couple weeks ago.
And I didn't even get any.
I know. Me and Ben hogged it all. It was one of the smaller, like the 350 mil ones. So, a couple of swiggies and sucker was gone.
Couple of swiggies. I love it.
Yeah, it was easy. All right, listen, we actually do have stuff I want to talk about. And the first thing I want to talk about, which we talked about, which is Bruce's baby, Jackson. Love that name, by the way.
Doesn't that sound like a girthy name? Is that, I don't even know if that's a word, but right, doesn't it sound like it sounds robust, it sounds thick?
It does. It does. I agree.
That's not just me, right?
I don't know that I would have used girthy. This is me. I'm just saying. But I know exactly what you're saying, and yes, it's like it's like a stern, it's like manly. I don't know. It's good. I know what you're saying.
Was there any family choice for the names, or you just like the names, or?
Honestly, it was the only name that my wife and I could agree on for a boy. And it was really like, we just both were kind of like, you know what, Jackson, we both really like it. It just kind of just stayed. His middle name, Lee, is where some of the familial, relevance comes in. Both my grandpa and then Stephanie's dad.
Oh, nice.
So tried to incorporate a little bit of family into the name somewhere. And so we came up with Jackson Lee.
That's awesome.
That's outstanding.
I love it. All right, let's jump onto this. I'm going to hit this button. I have no idea what's going to happen. Oh, it took me away.
See, I see a thing that says headache on it.
Mike, you are back now.
Yeah, it's so weird. Like I'm still.
Now you're gone. This is some high-end entertainment. We're getting. This is called Watch Us Fumble.
You know what, though? I have to tell you, so far I really like the fact that you can broadcast to like 3 or 4 different platforms at once. I think that's like a huge benefit.
Yeah, I agree. It's tougher because when we were doing using the other product, the comments from the Facebook stream were sort of built right in, and we're having to watch them on the side. That's why I keep looking over here. I think we will get the Facebook stream part fixed because there's an API that'll bring those into here, so we'll be able to do that. But it wasn't working this time. Like I did everything I could do. This is quite complicated, by the way. What are you going to do? Whatever.
So I think, Mike, what you said is that it's almost easier if you have somebody kind of in the background manipulating kind of
for sure.
the operations of it, and then you have the guests on that are just kind of bantering back and forth.
Yeah. Wait till we have our iSimulate Reality 360 plugged into this, and we're going to be doing case reviews. We're going to be doing all kinds of stuff. It's going to be amazing. But what I really want to talk about was we just had a release of a Lighthouse Project podcast. That was actually sort of unique, and we've got some really good feedback on this episode already. So do you want to talk about a little bit about that, Jeff?
Yeah. So first off, guys, I am so sorry. My video is not behaving itself. I had worked really hard to get some nice lighting and nice video, and it obviously worked out well. So, so we're trying to change the format up a little bit to bring Mikey back in. I was missing him.
Thank you.
2 is to break up the format so it's not just me blathering on and on and on about a paper.
Thank
So
God.
one of the ways that we've done that, the episode 32, I think, was with Dr. Kovac. So we had somebody come in, a subject matter expert. And then this last episode, we brought in an EM resident who was a paramedic. Well, she's still a paramedic. And she ran through an oral board scenario talking about the thing we were talking about, headaches. So
Yeah.
I think it was pretty helpful. Went over differential diagnosis, some pathophysiology, some pharmacology. And I kind of liked it. Hopefully other people did too.
Yeah. So if you've had a chance to listen to that, or if you have not had a chance to listen to it yet, definitely check that one out and then just give us some feedback. We got a great email today that from somebody. I'm not sure if you had a chance to see that, Jeff. I'm not sure what your schedule's been today, but with some just great feedback and some other thoughts as well as how we can maybe. Yeah. So just throw a little hat tip to James for giving us that email, but we're always looking to improve it, make it a little bit different. And if you did listen to it, you might have noticed some music in between a couple of the segments there. That's from one of our people.
It
Right,
is.
Jeff?
It is. It's from one of the commanders at Williamson County EMS. His name is Jeremy Stimson. Jeremy, thank you so much for letting us use the music. He's a great musician, and he puts stuff up on SoundCloud all the time. And he said, hey, feel free to use some of my tunes. So I like it. It's a nice little breakup between segments.
We should link his SoundCloud on one of the.
Yeah.
So other
We
folks-
should do that. Now I got to figure out how to do that, but we can definitely drop it in the show notes. So we can do that. I know how to do that.
Yeah, put a link in there.
Yep.
That's good.
We
Well,
can do that.
I want to see what happens when I know this isn't going to work, but maybe if I'm going to experiment and try to get my next photo in here that I want to put in here.
Hey, while
Let's
you're
see if
trying to
this
do that, I need to make a plug.
Yeah.
A
go ahead.
plug and a thank you. So y'all were talking about what you're drinking. I decided to go back to beer. I'm drinking a local beer. So this is Real Ale Brewery in Blanco, Texas. So this is the Lost Gold IPA. They have quite a few great beers. The cool thing is they sponsored, so Blanco is out in the hill country and they sponsor a bike ride called the Real Ale Ride. You probably can't see that very well. But it is 70 miles through the Texas hill country. It's an awesome ride. It goes right through Luckenbach, Texas. And if you don't know about Luckenbach, well, I'm sorry, you should. It's an iconic place that Willie Nelson and his folks made famous. And so you basically can't go through Luckenbach without drinking a beer. So it's at about mile 50 of 70. And those last 20 miles after you've had a couple of beers is it's a thing. So it's a new experience.
When you brought up Willie Nelson, I thought you were going to say you can't go through without like smoking a joint, but I get that. So.
This is a
Right.
family show, Ritu. And you got to remember that stuff's still illegal in Texas.
That stuff is legal in Oregon, but when did this become a family show?
Yeah, good point.
Yeah.
So I have a plug
The
to
green
do.
room was certainly not a family green room. I'll just point that.
It definitely was not a family
preferred,
group.
I think. So I have a plug. So I want to see how many of y'all have read this book
Ready Player One. Seen the movie.
or seen the movie at least. So check this out. I have an autographed version of this. Let me see if I can find the autographed thingy. See, nice and signed. Ernest Klein, the author, is the next door neighbor to one of our ER docs. And he said, listen, in Austin, and said, y'all are getting your butts kicked from all of this COVID madness. People are being idiots. I just wanted to let you know that I really appreciate what y'all are doing. So he signed a shit ton of his books and donated them to all the docs and nurses. So thank you very much.
That is so cool.
I
Amazing.
thought
If
it
you
was
have one left over, send it my way.
And if you have not read this or his other book, Armada, it's outstanding stuff.
Yeah.
This is all about 80s, like pop culture, sci-fi, gamer, basically my nerdly life.
Yeah.
The
Cool.
book is so much better than the movie. Do yourself a favor.
Are there instructions on how to get your camera working in there?
Unfortunately not. Yeah.
All right, I was just checking.
Hey,
So,
Ritu,
I don't know
just to check, Ritu, not a family show?
Yeah, I heard not a family show, and then you.
Good.
I couldn't hear what you said.
Just confirming this is not a family show, right?
This is not a fucking family show.
All right. Fuck off, Mike.
Right, whatever. That's good. So speaking of about the situation, you might notice that other picture that I decided to throw on here. I don't
Yeah.
know if you can see that or not.
Oh, yeah.
See that?
It looks like Mike, you must have had a headache and we're getting a sphenopalatine ganglion block.
Right. Yeah, it was definitely not soaked in lidocaine or anything that we talked about on our podcast. But yeah, that was my that's a still from my GoPro when I went and had my COVID test. I figured I would just grab a little still picture off there, and that's about the worst of it, right? Of course
you would.
Yeah, it was. I figured I would just do it.
Now, did you get a video, Mike?
Yeah. Oh yeah, there's a video. Don't worry about it.
Are you going to share with us?
Yeah, maybe at Fast 21.
All right. All right.
Where is Fast 21 this year? This next year?
Las Vegas, baby.
That's right.
Planet Hollywood
Vegas.
Caesars.
All right, let's do some EMS things. Well, here, let me try to show you this. This is what happens when I put a picture in this little spot here and I want to send it live. I will show you what happens. And if you're still watching after all this shit show that's going on, thank you for that. We love you.
God bless you.
But I tried to get a picture of Ashley Bauer and their dog Paxson. So you see it is not formatted correctly. For some reason, it is not. So if you're on your phone, turn your phone up and take a look at that sweet little guy. So that was Paxson. He was 7 years old. Eric and Ashley had to unfortunately put him down. He passed away this morning, actually, I believe it was. And so never a good time when one of the animals has to go across the Rainbow Bridge. So lots of love to Eric and Ashley and their family. Just is terrible, right?
Guys, I am so sorry.
Yeah. He was a sweetie too. I'll tell you, he just he was always happy and did his own thing. And he ended up with some kind of lymphoma or something. And it just whacked him. So not awesome.
I'll tell you what's really interesting. Every time I've been down there, he is like the most gentle, loving dog on the planet. They have a few dogs that have some pretty strong personalities and don't mind throwing their weight around.
That's for sure.
Speaking of the fatties, but Pax was just a gentle and super loving friend down there. Always made everybody feel super welcome.
Yep, indeed he did. So Eric put a nice little tribute on his Facebook page for that little fella today. So anyway, lots of love to you guys out there. And I'm sure you'll watch the replay. So we just wanted to try to throw that. Sorry, it's upside down. I have no idea why. Just more weird, goofy stuff. So I put a Facebook post out today on all the social media sites for FlightBridgeED, and it was a scenario based. And this is the post right here. You might have seen it, you might have not, but essentially this is kind of the deal here. It's a 36-year-old male on a motorcycle T-bones a car. So we are right smack dab into the driver's side door of this car. He's alert and oriented, and somehow his only complaint is severe, and I'm talking severe, neck pain. He has no deficits, no other distracting injuries, and doesn't appear to be under the influence of drugs or alcohol. And he can move all extremities, but he tells you that he's afraid to move his head. Helmet off. Yes or no? So this is one of our first little, it's not really one word, but we're going to play a little game in a little bit. But let's start with Dr. Sani. What do you think about this scenario? Helmet on or helmet off? That's very controversial, by the way, it seems to be.
Well, so, I mean, there's so many thoughts going through my mind about proper immobilization. More importantly, does proper immobilization even really matter? The patient who clinically worsens because they moved, is that a myth or a fact? That's really the fundamental question, right? I can tell you that this idea that you immobilize the person and that the hospital is going to know what to do with it is bullshit. Hospitals will take one look at it and go, "What the fuck is that?"
You people need to get this off.
That's not so. And having worked at multiple level 1 trauma centers in my day, and besides being an EMS medical director, so I would say that and especially there were some comments that I read, especially if it's a newer helmet that's sort of better equipped to be removed, I would recommend sort of moving it. There's no right answer. I can tell you that, again, the idea that he's not paralyzed yet, but going to be paralyzed is something that we teach everybody, is our argument for proper mobilization. And I still think it might be bullshit. So that's my thoughts. So
Bruce,
at some point he's got to get out of the thing. And I don't know that the hospital is any smarter about it than the EMS is. They probably are less smart about it, actually.
Yeah. Bruce, what are your thoughts?
I kept it very simple. And I said, no, I don't think I would have, but I wrestled very much kind of with the same things that Ritu just mentioned. There's a few things. It's a dynamic, it's a fluid situation. I think if there were immediate airway concerns, I would likely err on the side of caution and do the best I could without removing it. But when it comes down to it, if you have to take it off, you have to take it off.
Right. Yeah, that's what I was thinking. Jeff, what do you think?
Well, so I think I missed the scenario to begin with, and what I understand is a 35-year-old dude, significant trauma on a motorcycle. He's wearing a helmet, and he has midline point tenderness over his neck. Is that right?
Yeah, he's complaining of severe neck pain, does not want to move, but has no other distracting injuries. He doesn't seem to be under the influence. Nothing crazy.
So he clearly fails Nexus, and you can't clear him. But does he have any neurodeficit?
Nope.
Okay. I think I would probably take the helmet, and he's not wearing big bulky pads anywhere else.
No, I didn't really add that.
Wearing a football uniform. But,
well, that's kind of the question, right? So I think I would probably take the helmet.
Driving over football practice.
Yeah, I think I'd probably take the helmet off, and the reason I would do it is for exactly the reason you said. We are actually trained to do that, and at least in my emergency department, nobody else is. And I think we would probably be able to do a better job of maintaining neutral alignment. Lack of literature on the subject notwithstanding, and I completely agree with Ritu that we don't know. If he's not pithed now, the likelihood of us pithing him is probably pretty slim. But for no other reason than I think he's probably going to be more comfortable without the helmet on. And we have more access to the stuff we need to get access to.
So Nick Adams asked, is the patient sort of better controlled in the hospital?
Yeah, meaning can we better stabilize the patient while we're taking the helmet off in the hospital?
I think so, and I think the question has to do with the scene. Is it more chaotic at the scene versus at the hospital?
Yeah, I think my take, having been on the scene and in the hospital, is I would not necessarily assume it is less chaotic in the emergency department. Particularly, let's see, what day is it right now? Particularly right now.
Yeah.
Not to, cast dispersions on our brand new rising colleagues, but yeah, I think we would probably be better off going ahead and doing it now. Thank you.
See, I've thought about what you all told me, and I think I've changed my mind, Mike.
You're going to take it off?
No, I said I would take it off. I think I'm going to leave it on, but I will walk him to the ambulance.
Oh, that's perfect. Yeah.
Now, Mike, walking to the ambulance is only okay if you climb up into the ambulance and then you put a C-collar on and put them on a hard, rigid backboard.
Yeah,
that's the only time walking is okay.
Yeah, I could see that.
Or you walk them to the back of the truck and then do a standing takedown in the back of the truck.
You beat me to it. The standing takedown, one of my favorites.
Standing takedown.
I used to love that back when I thought that did something good.
So Tim brings up a good point on Facebook. He says, as a rider, helmets are like strapping a lead brick to your head, basically. Food for thought while riding in an ambulance and moving the patient around. So yeah, I mean, that makes a lot of sense. I mean, you're right. I think it's going to be half and half. People want to leave it. So my initial thought was definitely leave it on unless there's airway problems. But then I get to thinking, by the time you realize there's an airway problem, now you're going to fumble around with the helmet and try to get the helmet off a guy. And I've seen and heard of all kinds of gadgety things to get a helmet off somebody, right? Have you seen, like, you take the blood pressure cuff sleeve out and you put the bladder up on the thing and you do some squeezing, and I guess you name it, you can find any way to get a helmet off. But I don't know how you would do a super great job of I know you can kind of get in there and reach up in there while somebody's pulling out on the helmet and trying to like maybe tip it forward a little bit and kind of ease it off that way. There's just probably no great easy way to do it. I mean, I don't know. Am I a fence sitter? I don't even want to answer my own scenario because I don't know. I don't know.
Well,
like in Sam's scenario there, it sounds very much like there is a story to that, but I'm kind of liking his approach here. Have somebody take a saw to both sides of the helmet. I'm sure that would go over well.
Oh, well, that works.
I would just use a hearse tool. Just slide
there you
that
go.
right in there. Pop that baby right off.
That's so good.
So is there any like, could you do an X-ray or like a CT scan, or would that cause too much like
there's probably metal.
Yeah, they would freak out. That would be, because the other piece too is if the airway is going to crump, you don't want to spend the first 30 seconds of the crumping airway trying to get the helmet off.
Yeah, that was my thought.
I can remember, I'm thinking back, like I can remember a motorcyclist coming in with a helmet, and it was, we actually still did like, airway's good, breath sounds are good. And then the next point, just get that thing off. And it's hard to immobilize a person in a more neutral position anyway. So the idea that you're gonna, make something worse, I don't know.
Yeah. Oh, by the way, I'm drinking Brook Laddie, 2011 Isle. Yeah. So,
now,
Scotch.
We discussed this before, Mike. How confident are you in the pronunciation?
100%.
Are you really?
Yes, I've watched a documentary about him, and I heard him saying it that way themselves.
So the reason I say this is the word ends in CH, right?
Mm-hmm.
So I did a Google because when you told me that, I was drinking Glenfiddich. And I said, well, how the hell is this Glenfiddich? Being a typical stupid Texan. So I Googled it, and there's some pissed off Scot, and I realized I repeat myself there. And he was telling me how to say it, and it's
well, it's entirely
it's different.
I'm telling you, I heard the master distiller from Brook Laddie saying it that way. So I feel confident in the pronunciation.
Perhaps we have some experts on here who can not only resolve this issue for us, but recommend some additional scotches that perhaps we have not tried yet.
Yeah, there you go. All right, we're gonna try.
I saw Dave Lincoln pop up there. Yeah. He's one of our chiefs at Leander Fire Department. He says they have a lot of saws on the ladder truck. Well, they also have a tiller truck now with so much room that I'm sure they have all sorts of stuff that would not actually be helpful. But I'm sure he would be happy to bring it to the scene in a really cool looking truck.
Well, yeah. Tillers are the best.
Tiller's pretty cool.
We got 3 of them our darn self at my agency. All right, we're gonna play a little game here. And I'm glad Bauer was not on here because he had a lot of anxiety about this. Like a lot. Because he doesn't like, because I'm not telling you You guys have no idea what this is even about. Like, I'm literally springing it on you. And I want people that are watching to sort of chime in too. But essentially, what one word is I'm just going to give you, guess what?
3 words.
1 word.
2 words.
I'm giving you one damn word.
1 word.
And I want it to spark a little discussion. And so I'm going to assign a word to each of you, one at a time, of course. And so somebody's going to get the first chance at it, and then we'll just discuss it.
So is this free association?
Yeah. And but what I want you to associate it with is, EMS, which is kind of what we do.
Well, yeah, I'd say, does it have to be EMS?
Yeah. Yes.
Ratu is over there going, breasts.
What a goofball. All right. The first one.
Sorry.
The first one, I'm going to give it to Bruce because he may have to leave because he does have a 1-day-old. And by the way, it's just him and his son. That's it. It's 3 against 2.
Wow.
Right?
Literally, yeah.
The 2 boys in the house. That's it.
We are still outnumbered. What's up with this?
Yeah. Is this it, by the way? Are you going to have more? What's the thought?
So the wife said no more.
Copy. So
She
you're
laid
going
down the line.
you're going to go get taken care of, right?
Yes, and I've received about 4 or 5 videos from friends over the last several weeks, detailing out their experiences, either in video form where they can, they're doing the manly shuffle right out of the office or something like that. I don't know.
Let me tell you. I had it done in 1990, 98, 99. Easy.
That's the same thing Bauer said. Yeah.
Easy. I went to work 2 days later.
And Bruce, I can tell you, I got a lot of vet buddies down here in Texas. If price is a concern, I can get you set up. Just
not in a billion years.
All right. I'm giving Bruce the first word. All right. Think of this in the clinical context.
Yeah.
And Bruce's word is preload. Preload.
Just let me ramble on about preload, what I think about it.
Yeah, just give me a little something on preload, and then we'll start the discussion.
Yeah. So one thing I thought was very interesting when, back in the day when I first started in the intensive care unit, everybody was hooked on this whole idea of putting like an IV in maybe the patient's hand, arm, wherever, hooking it up to a transducer and basically getting a central venous pressure or right atrial pressure. And then we kind of migrated into the whole Swan-Ganz thing, and we could float catheters into the thing. And I got to tell you, I never really trusted it. I don't think the values, even on a Swan-Ganz catheter, right? Like the measurement of CVP and how that correlates directly to preload, I don't know. And then I was having a discussion with Tyler Christofoli, and I said, what do you think is a really good way to measure preload? And he said, well, we have this thing called an ultrasound, and you can take a look at the inferior vena cava, IVC, and look to see, is it flattened, is it engorged, and use that as a driver to determine fluid status, volume status in a patient. Totally blown away, love it, and I still stick to it this day. But here's where I'd like to bring in, the 3 of you from a literature standpoint or from an evidence standpoint. Does that hold any water? Where does the relationship between ultrasounding or taking a look at the vena caval space and whether it is engorged or not, and relating that directly to volume status as an indicator of preload?
Great question, Bruce. Ratu is just going to sum that up in a really concise statement.
Yeah. What I know is
click.
Here's my take on that. And Tyler is on. Well, he was listening, so he'll probably, start yelling the answers. So that's fine too. But so ultrasound is one of the things that I like. I'm not an ultrasound like zealot aficionado. Love. We do have one guy in my shop in emergency medicine who's very much into ultrasound. And when you can't find the ultrasound machine, it's often because Tim has it. But his feeling for a long time, he was very strongly pro, especially of course in sepsis, using it. And the best way to describe it is that it's a tool. It's like anything else. It can be helpful in the context overall. Some of the data about it being sort of an absolute decision maker is probably pretty poor. It's still kind of the secondary way to measure it. And the other piece too is sometimes your patient has preload that you need to overcome, right? Or if you think of shock from a PE, when you look at that IVC, it could still or an RV infarct, you could see an engorged IVC, but they might still need more preload. So you have to take it into context of your patient and overall patient care. But I do think that a collapsing IVC is sort of a sign that says, yeah, this patient could use more. Certainly, if you have a collapsing IVC and a good SAT and they don't sound wet, more fluid is kind of how I look at it. What do you think, Jeff?
Well, I'm actually typing away and PubMeding as quickly as I can. And overall, I agree with you. So this is not a literature-based answer. It's just what Jeff's clinical practice is. And I do the same thing. I also did, when I was in residency, we were dropping lines and everybody getting CVP pressures. And I think they gave us about, once you started getting literature on it, they were about as helpful as Swan-Ganz. They just didn't change mortality. Maybe this will be different. We're getting beat up by the sepsis Nazis that we have to do some sort of measure of fluid responsiveness. This is probably as benign as anything else. I did find there was the top hit on ultrasound inferior vena cava fluid responsiveness is, this looks like an editorial, but I like the title, ultrasound assessment of the inferior vena cava for fluid responsiveness. Easy, fun, unlikely to be helpful. And now I'm just looking for some actual literature. So that's my thought on it.
Well, that's fine. But again, like the idea behind kind of one word here is just to generate a little bit of discussion, which I thought we did. And there's been some great comments on Facebook, at least. Nothing really happening comment wise over on Twitch or Twitter, and that's cool. We just want to give people options, right? I don't care where you watch it.
Let me add on to preload here. So there I was. It was 109 freaking degrees in Central Texas. And my shiny
today
needed today. It was ungodly hot. And getting hotter over the next few days. So I was down by the pool and I get a call from one of my Marble Falls medics. So let's talk about preload. 92-year-old woman, new onset AFib, RVR, not otherwise anticoagulated. Heart rate's in the 150s, 160s. She's confused, and that is new for her. And her blood pressure is systolics in the low 80s. Speaking of preload. And it's a wide complex AFib. Go. So how do y'all manage that?
What was the blood pressure again?
YouTube. That's how I was managing it.
Systolic blood pressure 81.
And that's about how old she was, you said also?
No, she was 92. She's really hypertensive, and her age is still over her blood pressure.
Well, we got to give her a little juice, right? I mean, I don't think there's no question. We got to give her a little fluid. Who knows what else is going on with her? I would start with that. Start with a little bit of fluid, see how she responds to that. Now, this is in one of those cases of the chicken or the egg, right? So she just dehydrated. Is that all we're dealing with? She needs some fluid? Maybe. At least it's somewhere to start. I'm not super excited about what'd you say her rate was?
Well, it's a new onset of AFib with rapid ventricular response in the 150s to 160s.
Oh, I hate to do it to her.
You got to do it to her. Do it, Mikey. Do it.
I know. I know. Yeah, she's gonna ride the lightning, but
So
also,
I'll tell you, this is so. That's what I said too. I said, listen, go ahead and draw up some push dose epi. Sure, get some fluids going, but the rate is the problem here. She's going so fast that she has inadequate preload and her cardiac output drops. You got to control the rate. The challenge is that, the rate reducing drugs that we have here, diltiazem, beta blockers. So we do carry esmolol, but it's not on the truck for that. And amiodarone. All three of those can make your systolic blood pressure lower. Right. So there's a bit of a gut check when you're dealing with these patients. You're really comfortable that the blood pressure is low because of the rate. And if you slow the rate down, the blood pressure will come up. But the medications you need to slow the rate down lower the blood pressure even more. Now, in her case, I think it was fairly, she's old, she's altered. That's abnormal for her, new onset. So he shocked her a couple times, still did no good. Then he started in with some push dose epi and then started trying to feather in some amiodarone because it was a wide complex. And we don't have any prior EKGs on it.
Yeah, that seems pretty reasonable. Bruce, what are your thoughts? This was your world, brother. This is your world.
Yeah, so I guess
your word.
I guess one of the thoughts that I have is that, I think in paramedic school, what I was always taught, and even in nursing school, is that the problem with atrial fibrillation, especially new onset, is, kind of the risk of clot formation, right? Everybody thinks clot. When really the thing that I think you have to be aware of is the reduction in output, right? You're losing atrial kick. Right. And what is that? 15 to 20% of additional volume.
Yeah, 15 to 20. Yeah.
Yeah. In the ventricle. And so less volume in, less volume out. That's going to make her more hypotensive. No, that's a word out here.
Very medically sophisticated term.
Yeah. No, so I think a little volume would definitely help. And I think controlling the rate is the real problem. But I also think the atrial fibrillation is not helping the situation at all.
And and I guess what would be reasonable for fluid for this lady, going back to a comment that Joe Z put in here, when we first started the segment, he said the Starling effect, right? Starlings. Totally. So there's definitely going to be some benefit to that. That's going to help her out. But what's a reasonable amount of fluid to try with this lady that's 91 or 92 years old and her blood pressure is shitty and her rate's 160? And you got to tackle this from, you got to kind of do a flanking maneuver, and you also got to hit them from the air. It's almost like you got to hit them from all sides. And that's exactly what it sounded like you were talking about, getting some push dose ready in case that thing goes sideways or whatever the case may be.
We're getting some great comments on the whole AFib thing here. I love I've never heard the phrase Edison medicine before. So props there. I like that. And so Nick asked why push dose epi is superior to dirty epi, because we can get it faster. I think that's purely logistics. I don't think there's a really good literature-based answer on that.
Yeah. Although I will tell you that speaking of Tyler, he did a great video on this very topic on foam frat. It's probably been 3 years ago now.
Yep.
Where he went head to head with setting up drip or prepping push dose. And it was pretty much a draw. And the thought was, if it's a draw time wise, right, and you're good, and here's the key, here's the caveat of that: you got to know your equipment. You got to be good to go with your IV pump. There's a lot of things that need to be met to make this really true, right? So I will tell you that IV pumps can be for people that don't use them very often, but once a year, not super awesome. And Ritu, you were going to say something.
No, I just said, if you know your pump and can set it up quickly, that's great. Tyler's a flight medic flying critical care transports using his pump every shift.
Yeah.
Versus my field medics who don't know how to spell. Who just don't use the pump that often.
Yeah.
Yeah. And my guys don't have pumps. Hell, I have pumps in my ER. And God help me if I have to make that pump do anything other than stop beeping. I know the shut up button, and that's the extent of it. I'm a classic doctor there. I run with my tail between my legs looking for a nurse to save me. But the other issue is Tyler is also in a very compact area where he can reach almost everything and get it going. So I would say, I remember watching that video and it was a great video, but I think this is something that is highly dependent on your environment.
Yeah.
So I think your mileage definitely will vary there.
Yeah, I agree with that. I think that's fair. But I mean, and we don't need because the horse is dead. We don't need to keep beating it in the head. But this is just a shout out to those who take the time, make it a priority to get in there and drill with their equipment, get familiar with it, and really are diligent about knowing their equipment, because when you need it in a crisis, that's not the time to be fumble fucking around with this thing, trying to figure out, okay, why is it's an upstream or a downstream, and it's ridiculous, right? So I think that's the other piece that I enjoyed about Tyler's videos was he would put himself, and he would, and it's a little much for most people, but he would record himself in the seat in the action seat in the helicopter where he's at, and he wants to know, what's in my right arm's length reach. What can I put here that I might need, or what can I hang behind me and be able to grab it, or what can I put in my pocket, or my left outside, cargo pocket down by my ankle. What's the most useful thing that I can put there, right? So he's really taking it seriously, and not that other people don't, but maybe he takes that to the next level because he knows that the patient might be counting on him being proficient in that moment, and not have to wonder, where did I decide I was going to put this thing? So anyway.
So what's really interesting about that, if I can just mention, so having just been in a labor and delivery room, they are really good. That is one group of people who are phenomenal at preparing for kind of the worst case scenario. Like they have everything lined up, and they know they're not, they're only going to use maybe one 1/100th of the equipment, but they have it lined out, checked, and ready to go. That in case something happens, right? I mean, when you're delivering and you got a gush of fluid and a baby on the way out, I mean, you got literally 20 seconds to kind of, get some critical action or intervention in place. So definitely agree with that.
All right. Do we want to move on to the next thing? Does anyone got anything that they're dying to say about?
Well, I want to introduce.
Do you see where we went with that? See, I mean, we've been all over. So don't tell me you don't love one word. I mean, we covered the gamut.
I do want to take a moment, Mike, to introduce we have a special guest. Do you have them teed up?
Oh, do I have a special guest?
No, yeah. Just want to welcome into the house Tom Hanks, ladies and gentlemen.
Oh.
No? Tom Hanks?
I don't know. No Tom Hanks.
Fellow birthday boy.
All right.
Hey, Ratu,
you had me going there, brother.
Ratu, my 53-year-old friend, I have some video tips for you from personal experience. Don't do this.
Oh, it shows off your big balding heads.
Sorry.
Yeah. This is the other reason I think I need to do the mic thing here is as my hair is getting a little longer, the gray in it is becoming more obvious, and this is a bad thing.
Oh, the gray's nice. My hair's getting. When we opened up, I'm like, my thought process was like, if I'm gonna get a haircut, I've got to do it now, because we're at the low part of virus in the community, because it's only going to go up. So literally the first day that my barber opened up, I went and got my hair cut, and that was like 3 or 4 weeks ago. And so now my hair's getting long again.
I got a pair of clippers.
No, I like it. My wife likes it, so it's good.
Hey, before you one word, I have a new addition. Y'all remember MASH?
Yeah.
The show, and Radar O'Reilly, who could get anything. Well, every department has a Radar O'Reilly. Ours is Mario. Mario got me a new respirator. It's a nice small one. I like it.
So the thing about radar was he could hear the helicopters before they were coming.
Yeah.
Yeah.
Duh. Like that was a whole weird thing. That whole
What?
thing was weird. Was it weird? It was weird to me.
What
I
was
don't know.
weird?
Maybe it's because I was busy multitasking and I didn't hear the whole story. And so like you put something in the middle of the screen. And I don't know what it was. And there was radar and MASH. And I don't know what the hell you're talking about.
He wanted
Should
to
we
show
just
off
move on?
the respirator.
Oh, the respirator. That's what it was.
I
His
did,
car-
and I wanted to thank Mario. I wanted to thank Mario for helping me get one of these things.
Oh, it's so good. All right. Would you stop? Because I'm going to give us,
Finder was before radar.
I'm giving us the
Yes.
next one word.
Klinger.
Can I go?
Before you go, I do
Chat,
have to
if
say,
you're in the chat, you need to help me out. Can we go on to the next one word?
one of the things that is a little distracting is there is just a little bit, quite a bit of AV desynchrony here.
I told you, don't get distracted, man. Stay focused. Just listen. Listen to my voice.
Walk me home. One word, me baby. What's up?
This one's for Ritu.
Okay.
Are you ready? All right, here we go. EMS documentation.
Lies, damn lies. All of it. I can tell you exactly what did not happen on a call.
Based on the chart?
What's in the chart. That's exactly what did not happen.
That's not always true.
It's always true.
What did not happen is in the chart?
Yep.
Oh, I guess I see what you're saying. You were doing a play on words there, and I got me confused.
Yeah. EMS.
But besides lies, damn lies, talk to me about it.
We've had this conversation many times.
Are you saying? Are you revealing to the audience that I may have thrown you a softball here?
No, you didn't throw. You didn't say like Big Ten football. That would be a softball. But
that's true.
No, so documentation in the emergency department, documentation in EMS continues to be a challenge, and in a lot of ways. But fundamentally, no matter whether you're doing it on a great platform like ESO, whether you're doing it in paper, it hasn't changed in 100 years.
Agreed.
Right? You are still, maybe you're not taking the crap you wrote on your glove. Maybe now the monitor's pushing it in, so that's a little bit better. But you're fundamentally taking your memory and your partner's memory of what happened on that call and sort of retrospectively putting it in a narrative. And
yeah,
Jeff's an emergency doctor. I'm an emergency doctor. If you need to buy a fucking used car called "This patient needs to be admitted," I will sell you that used car. So
speak for yourself, Ritu. I never oversell an admission.
So
that life-threatening sodium of 128.
I tend to be I'm sorry about this admission kind of guy, but I've tried to do everything I can. So I don't sugarcoat it but we definitely, all of our documentation reflects the bias of the story after the story is completed. And
so
yeah,
I'm sorry. Go ahead.
No, go ahead. Go ahead with your question.
No,
yeah. So Ritu's point.
Hold on a sec, Dr. Jarvis, because this question pertains to you too. Is that I know, at least at the place that Dr. Sani works, that he's got a little dude or a little gal following him around that's taking notes on what's going on. Is that not true, Dr. Sani?
Yep.
And do you have the same thing, Dr. Jarvis?
I do not. Well, unless I have a resident.
Oh, okay. So how much does that help you, Ritu, in your when you're going back into that chart and writing notes? Like, is that invaluable?
It's for me, it's pretty valuable for a couple of reasons. And it was funny because John Jew and I talked about, could we have EMS scribes? We had this conversation.
Yeah, I love that idea.
Explain what you mean.
Have a person who rides around with the EMS crew and it works as a scribe. And I will tell you, I work in a moderately busy place, not a super busy, but not a quiet place either. You know, we're pretty much at the ACEP recommended average for patients per hour. We are higher than the average acuity though. So I'm fairly busy. And so my little scribe person, the biggest task that I consider them is a cognitive unloader. I don't spend any time in my shift thinking about when am I going to start this chart, when am I going to and how am I going to document this chart. I let them do that. Now, the challenge with scribes, we have new, you know, they're 20-somethings who have, in some cases, no medical experience. And so when I collect a history and they put it in the HPI, they don't necessarily understand what are the important pieces and what are not. Yeah. So it'd be sort of this unfiltered. And then last week they walked down the street and they saw a funny rabbit, and then they complained of a twisted ankle.
Okay, I see that.
But they're here for chest pain. I don't need that, even though. So there's a little bit of that. So that they're a cognitive unloader. But in response to some of the things we talk about in EMS charting and in medical charting in general, they're a little bit better about catching the things as they happen and what happens. But even then, I'm going back in using my memory as to what happened in the case and documenting, kind of correcting the documentation and that sort of thing. It's still a relatively retrospective memory as to what happened. And so we're getting better at capturing the data. So now you put your procedures into separate data fields if you do it correctly. So if you and I want to, you know, and between all of us, I mean, I think Jeff Jarvis is probably one of the best medical directors in the country at extracting data out of his system. We're able to extract more data, and I think that's really good. But we fundamentally still have a retrospective review memory as to what happened. Most of our times on the charting are how many people are really hitting the clock on the monitor. Not many, so they're all approximate. The dosing of medicine is the dose you thought you gave, not what you actually gave. And there's lots of data that shows that with PEDS cases, what you thought you gave and what you actually gave, what you thought you gave and documented is not what you actually gave, right? So I think that at some point in the future, there's got to be this break where we're collecting data in real time, probably through body camera technology and technology on the ambulance, and then distilling down what really happened into some sort of transcripty format. That's what I would love to see in the future. I think AI can do that sometime in the future. It removes the challenge of having to worry about your documentation, but it also, scarily to a lot of people, documents what actually happened and not the story, necessarily the story you want to tell, which may be two different things.
Yeah, I'll let Dr. Jarvis go because I know he's chomping at the bit, but I just want to say that I totally agree with you. And there's again some good comments on Facebook and even a couple over on Twitter about this topic. But yeah, I mean, we talked in depth about this while we were in Ann Arbor the night before the big game against Iowa. That was pretty awesome. Down in the basement eating some was it Thai food or something? Anyway, it doesn't matter. But we talked about documentation a lot, and there seems to be some discussion about, at least in the chat, about thinking that we do a good job of documenting nowadays, and that somebody doesn't necessarily, I think it was Nick, was like, I don't know that I agree with Dr. Sani on that, but and that's okay. But I agree with Dr. Sani. I think we're probably not very awesome at documentation. Has it gotten better? I don't know. I'll let Dr. Jarvis answer that because he's sort of into it. But what are your thoughts, Jeff?
Well, so I think they're just looking at a couple of things. What I was going to say is the way I don't have scribes. I think I wish I did, but I'm not sure how much they would really help me. Now that's coming from someone who's never had a scribe, so maybe they would be great. I don't know.
Yeah.
I think what I would I can tell you that a fair amount of the stress that I go through in a busy ER shift is worrying about my damn charts, because I don't want to get come home and now have to spend 3 hours trying to remember which patients there were in a busy shift. I can promise you, I don't remember at all half of the patients that I saw, 3 hours ago.
Can I ask you a question about that?
Yeah.
When you're doing your charts afterwards, are you on Epic also?
Yeah.
Yeah. So before I had a scribe, I would find that the charts that I at least had some stuff down were so much easier to quickly get through and get done.
The ones that are the worst for me are the left without being seen. So there are no notes anywhere, and just this annoying little thing from Epic saying, where's your note? Where's your note? Where's your note? Like, I don't remember a damn thing about this patient. And it turns out the reason is because I never saw him. So we click on patients early on because me and my partner will do every other. So you click on them to assign them. I will tell you, I saw Brett in here somewhere said he would kill for a good voice recognition in ESO. So I don't blame him. That's exactly what I use in Epic. There is a thing called M-Modal. And basically, I just grab my phone and it establishes what I'm assuming is a Bluetooth connection. And I dictate my H&P and I dictate my MDM. And that is by far the fastest thing. And then the stuff that's the bane of every ER doc's existence is the stupid review of systems and physical exam. It really is just kind of pointless. You're not getting good data out of that. Very little. I care about neuro exams and I care about belly pain exams, and it's kind of about it.
Bruce had to dip out, just so you know. He was being summoned.
Anyway, right?
Yeah. He was being summoned by his wife.
Yeah, so
he should absolutely follow what his wife wants. He should go.
Yeah, he ain't dumb.
Yep. Smart man. So one of the other things that I wanted to say is somewhere in here, we were talking about our Lighthouse Project podcast and going through an oral board. Yeah. I saw that Erin Lincoln was on.
She was. I did see her
I was
name.
already giving shit to her husband, Dave, about the tiller. So I saw her pop up. So hello, Dr. Lincoln. Yeah, she is a fan of Dragon. Yeah, so dictation's pretty good. And I'm actually really amazed at how accurate it is. It's pretty good.
It's okay. It's all right.
You're not a fan?
Well, I use Dragon. I think it's fine. I just like I have a partner who will I listen to him dictate into his Dragon, and he's like just whipping through paragraphs, telling a story. I'm like, holy shit, he's just pounding it.
Right. It must be amazing.
And then, like the next shift, I'll pick up a bounce back from him and I'll read his chart, and I no fucking idea what happened. It's like
it's just going in raw. He's not going in and checking it or anything.
He's just
blah blah blah. And that's
it. And in my opinion, because this guy's all about his opinion. This is and then he just signs it. Done. And I'm like, dude, man. There are a lot of words in there that have that are like make no sense to me. So
that's too much.
But yeah, I think it's And some, there were some interesting comments. Somebody mentioned that they think it's only a matter of time till we get body cams on EMS, which I think is a separate topic for a whole big discussion.
Is there anyone using body cams right now in EMS that's watching? If you are, throw your names in the comments. Maybe we can get you on our next live and we can talk about it.
I want to say Cypress Creek did that. Cypress Creek EMS. It's outside of Houston, suburban EMS system, pretty busy, and I believe they've been doing it. I could be wrong on that, but I think they have.
Remember the case that we talked about, that the case with the patient who ended up dying, that got recorded on the police body cam with the psych patient, where they dropped him off at the
at the truck stop.
And at the trucks, they dropped him off at an abandoned gas station. And the whole case was captured on the police body cam, and the EMS crews, we were all very angry by the complete lack of empathy and care that they had. And I'm not saying that's,
what do you want to bet that was a perfect chart, though?
Yeah.
No, bullshit. No.
You don't think so?
Hell no. No way. There's no way that was a perfect chart. In fact, I'd be willing to bet, and I don't know anything about that system. I couldn't even tell you where that happened because I don't remember. But here's what I do know. I guarantee you that chart was as shitty as the care we saw being provided. No question. No question. No question.
So that's a good point. If the chart is an accurate reflection of the care that we provided, maybe I'm just overthinking it, and we should just keep doing what we're doing. I just feel like in today's day and age, where I can get a fucking any food I want delivered to my door in 28 minutes, where I can dictate into my Dragon, where I can get a Uber to pick me up, and all the other things. Why are we still charting kind of like we did in 1980? And why isn't somebody working on tools to both make it easier for the medic? What's the other thing I often say? Nobody ever handed a medic a computer and made their job easier. Make it easier for the paramedic to care for the patient and not worry about these other things. And then get a better, accurate assessment of what happened, so that we can do a better job of evaluating care and creating education around the care that we actually see provided. And then, frankly, so there's added accountability, which we're public service agency. There should be accountability.
Yeah, I totally agree. We're going to go for 15 more minutes. There's a couple of quick shout outs that I want to do just real fast. And the first one is coming up on the screen as soon as I remember to actually hit the button here. And that is to just remind everybody that EMS World is virtual this year. So if you have not had a chance to check that out, I know, Dr. Sani, are you speaking at EMS World this year? I don't remember if you were on there.
I'm not.
You're not. Yeah. So I know Bruce is, Eric is, Tyler is, Dr. Jarvis is, Ginger is. We're, in fact, 3 of us are doing a podcasty thing at some point in there. I think it's on the Thursday, but definitely check out EMS World. It's a virtual experience this year. I know they're working really hard to make it good. I have done some virtual things. Some of them have been awesome. The one we did here in Oregon was great. It was just a series of webinars, and it was just wonderful. I had close to 900 people at one of my talks, which holy shit, that's a little nerve-wracking, but it was really super cool. So definitely check out EMS World Expo. FlightBridgeED is actually doing the critical care track for EMS Expo, so that's going to be pretty cool. Check that out. And then finally, again, as some of you may or may not know, but we've actually been hanging out with iSimulate since 2018. So they are an official partner now of FlightBridgeED. Oh, it looks like I got that little thing in the way. Let me see if I can move that out of the way.
Looks fine to me.
There we go. No, so maybe if I do that, then it'll show
Oh,
up
I
here.
see. You see the little. There you go.
Yeah, there you go. So anyway, so we have like I said, we've been hanging out with iSimulate since 2018. They were one of our first vendors for our very first FAST conference. So that was really cool. And we've been talking and hanging out. Believe me, let me tell you, they got some amazing stuff, and we're going to be working closely with iSimulate to give you some amazing education that you probably won't find anywhere else. And it's going to be right here on these live channels and some other stuff that we got working. I'm not sure exactly how it's going to work, but let me tell you, it's going to be good like you've never seen before. So I just wanted to get those quick shout outs done real quick before we got going here. But back to the situation. So I want to get to the situation here. We haven't talked a lot about the situation. Oh, but I did want to show my picture again because I know Dr. Jarvis wanted to talk a little bit about the situation. He still likes to call it the COVID cooties. I'm calling it, with Dr. Sani, we call it the situation.
The situation.
No. I call the situation COVID craziness or COVIDocracy.
Well, I've heard you say COVID cooties. I've heard
but there I'm talking about the virus itself.
Oh, okay.
It's
well,
subtle.
I know you had a thought about intubation, COVID, a bunch of stuff. So take it away.
Yeah. So I had a patient in a recent ER shift. Elderly person came in, trying to blur some of the details here. Elderly person with some chronic medical conditions, but basically walkie-talkie, fully functional. Over the last 2 to 3 days, they started feeling more confused, and then today became really short of breath. EMS got there, found them to be tachypnic with respiratory rates in the 80s. That's 80, with SATs in the 70s. So as a general rule, when your respiratory rate is higher than your SpO2, might be a problem.
Yeah. What did you say, Dr. Sani?
Respiratory rate in the 80s.
Yeah, he was pretty sick. So
and Jarvis rule. Your respiratory rate should never be higher than your saturation.
The Jarvis index. Yeah.
I like it.
So they slapped him on an non-rebreather, and SATs came up into the upper 90s. Respiratory rate dropped substantially, doing much better. Afebrile, no real history. He just smelled of COVID cooties. See, that's how you use that phrase, Mike.
Fair enough.
Smelled of COVID cooties, and sure enough, he had COVID cooties. He was positive. We had him in our 1 negative pressure room. What he needs is BiPAP. He was screaming BiPAP. He was also screaming intubation. But I walk in and say, "Hey, sir," and he opens up. He looks at me. He's responsive. He's talking. I'm like, I don't really want to intubate this guy. And what we do have is high flow nasal cannula. So I slapped him on high flow nasal cannula, and he tolerated it really well. So the question then becomes when to intubate this guy and when not to. Now, as it turns out, I turned him over to my partner because, as many of us are, we're boarding COVID patients in the ER, and it looks like he ended up getting intubated. And I'm trying to figure out, why did he get intubated? So talking to one of our hospitalists today, I had to go by and get this really sexy new respirator. And it turns out that he rode the high flow nasal cannula for about 4 hours and then started to degenerate. He started to get tunded. Respiratory rate went back up into the 60s. And I believe his SAT started dropping. So at that point, you don't have much of a choice. So, but it's a tough thing because we know mortality runs somewhere around 50% once you get on the vent. There's also this challenge that we know if we're going to intubate you, we would prefer to be able to pre-oxygenate you. And that, we're kind of limited. We can't put you on BiPAP for pre-oxygenation, at least, hospital specific. So it gets to be a little challenge. So, Ratu, what are your thoughts? Do y'all have any thoughts about? I don't suppose you actually have a protocol that everyone has agreed to about when to intubate, when not to. Do you?
In the emergency department?
Yeah.
Yeah, we so where we are, we're not in the same place you are. We didn't open things back up until things were actually going downhill.
That's a little jab there. That was good.
Yeah, we
Certainly not at Jeff, who I know how he was feeling at the time.
Yes.
So we're kind of in a different spot. So my volume has picked up, but we are not at the point where we're seeing a bunch of critical ICU COVID patients just yet. We actually had a conversation at our group yesterday about reconvening a multidisciplinary group. One of our partners worked directly with anesthesia and critical care to create kind of strategy around airway. But that was so early. That was back in the day where it was like remember when it all started, there was this like intubate people after 6 liters.
Yeah, exactly.
So we now know that the care has swung completely in the other direction, which is, especially given the Italian experience, which is many of these patients do much better on true high flow nasal cannula, not just taking a regular nasal
60 liters
to 12 or whatever, but the OptiFlow or other similar devices. So we haven't had that conversation yet as to so that's happening on a case-by-case basis, but we have a really good relationship with our critical care docs. So a lot of those conversations are happening in that manner. But I would say that I would have done exactly as you did, which was to look for an alternative non-intubation airway methodology, as whether it was, after the OptiFlow didn't work, I would have probably gone up to, I would have considered BiPAP. Although if he was obtunded, that's a different. You can't really do BiPAP at an obtundation. But I think that more of what we're learning is that these patients probably, if you can keep them from not being intubated, and I was talking to some family. I actually was talking to some of my crews, because everybody wants to compare this thing to the flu.
Yeah.
For whatever reason, because it's another respiratory viral illness, I guess. But one of the things that we know is survive or die, the time on ventilator for this disease is so much longer. So the resource suck that happens is the people who go home may have been in the ICU for 23 days,
right?
Ventilator for 18 of them. And the people who die were still ICU patients for 15 days. When people get sick with the flu, they're kind of better or worse in 3 or 4 days. So that's the other big resource suck that I don't hear a lot of talk about, is that these patients linger in either direction, and it can be hard. So I say that, that I think the right strategy is to do all the things we've previously learned to do to minimize intubation, because there is added mortality and morbidity if we have to tube you.
So looking at the Facebook comments, I'm seeing a lot of comments about these happy hypoxic patients. And so the concept there is that their SpO2 looks low, but they look fine, sitting up, texting on their phone. So that was not the situation of this patient. He was clearly in respiratory failure. So very tachypnic. The high flow nasal cannula, it turns out it bought him about 4 hours after I left.
Did you guys think about proning him or any other positional changes?
Yeah, so we didn't when I was there. So he had been on high flow nasal cannula for maybe 30 minutes when I had to turn him over and left. And looking at the chart and looking at what our hospitalist said, he rode the high flow nasal cannula sitting up, talking, eating actually, for probably 3 hours, and then started to degenerate. SAT started dropping, so they had to raise the FiO2. Then they tried proning him, and he didn't tolerate it. And I think that's probably what got him intubated. That and the worsening confusion. I'm still I put an email into my partner who relieved me. I'm still trying to figure out what his take was. I see Erin was talking about this. I think she's in downtown Austin, and probably actually has a fair amount more experience with this than I do. And she says they do the same things. The ones she's intubated were hypoxic and peri-arrest. And it sounds like at that point, there's not really a whole lot of, you don't have any options at that point. Yeah, it's a tough thing though.
Yeah. Hey, there was a question that Brian Liebig brought up about charting that I wanted to make sure to address. He said,
I want to get us out of here in like
3 minutes.
Okay, so he just wanted to ask, can we lobby for EMS systems to get access to Epic charts so EMS can read info on the patients without having to field the hospital has my medical info reply, blah, blah, blah.
I'd like to direct you to the HIPAA podcast that we just did right here.
Yeah, that's what I was going to do.
Yep, thank you.
Yeah. So yeah, there's it's not a HIPAA violation.
Right.
Short answer.
And it's not an Epic issue either, by the way. Epic actually has an EMS module, and they have the ability to give EMS access to the regular module. It's the local control over Epic, and I don't think anyone thinks, maybe some people think it's a HIPAA issue. Lots of people use HIPAA as their excuse.
Yes, they do.
They're like, I don't know HIPAA.
Right.
I don't know HIPAA.
JACO, Board of Nursing Examiners.
I know. Samantha is watching on Twitter. I was over there just a minute ago checking out what's happening
on YouTube also.
She was what?
She was watching on YouTube.
Hey, nice. Awesome. So anyway, she was our attorney, she's general counsel. She knows what's up. She ain't dumb. We talked about
Our lady.
Yeah, smart. All right, listen. Thank you guys for bearing with us. And I'm not sure how much. I learned quite a bit from a production standpoint, trying to figure this whole thing out. I think I've got it down. There's a few things I don't like, and we'll need to work through those, but that's okay. Where else should we stream? Does Facebook, YouTube, Twitch, and Twitter cover it? As soon as Instagram actually gets their shit together, we'll actually be able to stream to Instagram as well, but currently this is what you got. But anyway, we appreciate you guys hanging out with us. Dr. Sani, any final thoughts before we get on out of here?
Thanks for sticking it out, people.
Yeah.
7 of you, and sorry I missed the last episode, but
we missed you, buddy.
We'll get another second shift out there soon.
Yeah, we will. Dr. Jarvis?
Actually, you know what I think we should do? Because I'm feeling a little guilty that I, sort of hopped in on some second shift acts there. Maybe we need to bring Ratu on. And, now that we're doing oral boards, maybe Dr. Sani could do a case with us. What do you think?
Dude, that would be awesome.
Happy to.
I like it.
I think that would be cool. All right. So let's just get us out of here. On behalf of Dr. Jeff Jarvis, Dr. Ratu Sani, Mike Verkest, you've been watching a live edition of FlightBridgeED. So we've got the second shift and the EMS Lighthouse project covered. I mean, we've got it all. Appreciate you guys hanging out. We hope to engage with you soon. Stay safe out there. Wear your PPE. Do all your stuff. This is a Fire Dog production too, in case you didn't know. So other than that, you guys have a great night. Thanks for joining us. We will talk to you soon. Take care, everybody.
Bye, y'all.